Dear students, as a part of understanding the basics of the cornea, now we move on to examination of the cornea. Examining the cornea is not that very easy and straightforward. There are a lot of intricate points which are needed to pick up subtle signs in the cornea. Every sign in the cornea of a disease process will be very subtle and will need to be picked up and will need to be put together with all the other findings and the history taking from the patient and made into a plausible diagnosis. That clinical diagnosis needs to be worked upon by investigations, which we'll discuss separately as a PowerPoint. And once those investigation results also have come, then we make the full diagnosis of the corneal disease and take appropriate treatment measures as deemed fit. So when you are trying to examine the cornea, it's not necessary to straight away go to the examining the cornea. You will have to first examine the ADNEXA. So here you'll ask me, what is the ADNEXA? ADNEXA is the structures around the eye, like the lacrimal sac and the lacrimal drainage system is an ADNEXA of the eye. So you'll have to first clearly examine the lid margin. You'll have to examine the lid margin because you remember in the first slide we discussed that the lid margin has the meibomian glands which are going to secrete the important lipid layer of the tear film. So that way it is very important to examine the meibomian gland orifice. You'll have to see whether the secretions are properly coming. Are there any infection? Is there any blepharitis? Is there any inflammation of the lid margin? All these will affect the corneal health. So you'll have to first examine the lids. Then you'll have to examine the ADNEXA. Any chronic dacryocystitis might lead on to a corneal infection because it's a septic focus, neighboring septic focus, which constantly regurgitates into the eye and may lead on to a corneal infection. In fact, there is a favorite question by examiners. They'll ask you if there is a corneal ulcer, in a person who has chronic dacryocystitis, what infection you will suspect? Pneumococcus is the answer, because in a chronic dacryocystitis setting, there is a communication between the nasolacrimal duct, the nasal cavity, the paranasal sinuses, and the ocular cavity. So that way, we will be having transmission of infection from the nasal cavity to the eye. So the common organism which causes such a kind of infection is pneumococcus. Another important new thing which I'm going to expose to you here is to understand that there is an equipment called SLIT lamp, a SLIT lamp. This is a very important instrument used for examining the eye in detail. If you want to examine the anterior segment in detail, then you need to do a Pakka slit lamp examination. Slit lamp was invented by Gullstrand. This equipment, which we will discuss in detail in the next slide, has a powerful illuminating system and a powerful viewing system. So as you are simultaneously illuminating, you can view with magnification and minute focusing on the structures of the eye and get a detailed impression of what you are seeing in the cornea. This cannot be done with a torch light because as students, when you are in the ward postings, you will be using a torch light and you will be obliquely shining the torch light on the patient's eye and try to examine the patient's eye. This has limitations because the illumination is always diffuse. There is no magnification involved and there is no fine focusing involved. Whatever you are seeing is bit raw and bit more diffuse. And in that setting, to pinpoint small subtle signs in the eye is very difficult, very difficult. So any examination of the eye after a torchlight examination should logically proceed to a slit lamp examination for detailed evaluation and confirmation of even the simple signs which are picked up by a torchlight examination. And the third and the most important is tear film evaluation. Needless to say, tear film evaluation is a very important part of corneal evaluation, and we'll spend some time with it to understand the intricacies of the tear film and how it aids the health of the cornea, and how we'll need to examine a tear film adequately to understand corneal diseases. So here I'm showing you certain pictures of cornea, certain pictures of the cornea. One is this picture. In this picture, you will understand that there is a meibomian gland orifice. Meibomian gland orifice is seen. Can you see that white pouchings? These are the meibomian gland orifices. These meibomian gland secretions have to come out through this. I told you, no, if you remember in the first conjunctivitis session itself, we discussed about a gray line. This is the gray line. This is the gray line. This gray line is where the skin epithelium becomes the conjunctival epithelium. Outer to the gray line, we have the lash line. This is the eyelashes, and the root of the eyelashes are forming a line, and that is called the lash line. And inner to this gray line, we have the meibomian orifice line. So there are three lines in the eyelid margin, and this meibomian orifice line secretes meibomian secretions, which is a lipid layer of the tear film. So it's very important to see the orifices here opening up properly, not getting blocked, and no infection or no blepharitis in the lid margin. There shouldn't be any blepharitis or scarring in the lid margin. Next, you'll have to invert the lid and see for any follicles. Can you see small follicles? You can see them here. There is a follicle here. There is a follicle here. There is a follicle here. There are certain follicles here. So these kind of follicles, I'm sure you'll recollect that we discussed about the sago grain follicles in trachoma. So these kind of follicles are lymph nests which are inflamed. And if they are inflamed, then it means that the lid is suffering from or rather not the lid here, the palpebral conjunctiva is suffering from a infection, most probably trachoma. Similarly, you might on eversion pick up papillae. Can you see the papillae? Here? Can you see thickened epithelium? Can you see? They are described as cobblestone papillae in allergic conjunctivitis. Spring catarrh, seasonal allergic conjunctivitis or spring catarrh, you get this cobblestone papillae. So that is an important sign. You'll have to pick up. And the if you like invert the lid, there can be blepharitis. Can you see the lid margin is totally unhealthy? The lashes are matted. Can you see? The lashes are not separate. They are matted. And there is secretions pooling. There is a secretion pooling in the caruncle area, and all these are signs of a blepharitis, a conjunctivitis. So if these features are there, then you, with that feeling in mind, go see the cornea, because with these cornea might be affected. So with that background in mind, if you see the cornea, you will be able to pick up the subtle signs in the cornea. If you aren't aware of this, then you will fail to pick up those signs. This is a slit lamp. So this is the viewing apparatus. It has a viewing system, and this viewing system can be turned this way or that way. It can be turned this way. It can be turned the other way. Like it can be swiveled. It can be swiveled and shifted, and thus you can see the cornea cleanly and with focusing. And there is a magnification lever here. You can magnify it. 10 into x, 10x. You can magnify 10x or 16x. 10x or 16x can be the magnification. Similarly, this is the illuminating system. This illuminating system can also be separately swiveled. So you can illuminate the necessary area of the cornea and examine it by the viewing system. And this is the joystick. This is the joystick of the slit lamp, which can be used to pull in front, pull behind, push in front, or push sideways. All the movements of the slit lamp can be done by the joystick. Then this is the chin rest of the patient. So the patient comes towards you and rests his chin, and this is his hold. The patient can use this handle to hold himself, or else he'll feel very uncomfortable sitting like with the chin resting on the slit lamp. And this is the forehead rest. This is the forehead rest. This is the forehead rest. So we have a chin rest, we have a forehead rest, we have a handle for holding, we have a joystick. These are the parts of the slit lamp. The slit lamp can do again diffuse illumination. Just understand these here. In the next slide, I'll tell you images. I'll show you images of all these. It can focally illuminate an area. That focal can be a direct focal, or it can be an indirect focal. It can be an indirect focal. It can be a retro illumination. It can be a sclerotic scatter, or it can be a specular illumination. Usually the question here will be, if you want to study the endothelium, which is best? Specular. Remember this, because it's a common question. If you want to see endothelium, you will use a specular illumination. That is one interesting point here. So these are the illumination techniques which we saw in the previous slide and which you are going to see detail here. So this is a direct diffuse. It's very clear. Can you see? Diffusely the whole of the eye is illuminated. Now I see some conjunctival congestion here. The lid margin seems almost healthy. The cornea seems okay. Cornea seems okay. The pupil seems also normal. The pupil seems round and briskly reacting to light. So this kind of inference you make from a diffuse illumination. Then I have a doubt here. Can you see this area? This area I have a doubt. So then I put a slit. The slit lamp has a knob which I turn, it will become diffuse. I turn it again, it will become a slit. And this slit I throw on this area and see whether there is an involvement. If I throw like this, then I see something odd here. Can you see on the inner layer there is something sticking, something sticky, and something odd here, which makes me to like push the slit to a side. When I push the slit to a side, the slit lamp light which falls on the iris gets reflected and retro illuminates. This is indirect focal. Can you see? Indirect focal. This is a direct focal. Exactly where I want to see, I'm putting a slit. But here I want to see here, but I'm not putting the slit here. I'm putting the slit in the side and looking here. So this is indirect focal. This is retro. Retro is I throw the light into the pupil, and into the pupil the red glow is there. Against the red glow I see a posterior capsular opacification. Can you see? I see a IOL glare. I see an IOL glare, and I see thickening of the posterior capsule. This is the posterior capsule which is thick. This is called posterior capsular opacification. Similarly, I want to see a sclerotic scatter. I shine the light here at one limbus, and the light comes through the other limbus like a halo, like an umbra around an eclipse, like that. This is called sclerotic scatter. This I told you, no, this is specular reflection. Can you see the endothelium? I told you, no, something is stuck to the endothelium. Can you see? And these, what you are seeing as dot is keratic precipitates. What you are seeing as dot stuck on the back of the cornea is keratic precipitates. That is nicely seen here. Can you see these sticking things? That is keratic precipitates. So though you don't need to understand all these intricate examination techniques, at least as an overview, at least as an insight into what we do with the slit lamp and how we examine the slit lamp, I have taken you through a direct diffuse, a direct focal, an indirect focal, a retro illumination, a sclerotic scatter, and a specular reflection. Okay. The next interesting method of examining the cornea is to stain it. Cornea can be stained. We can use dyes to stain it. One of the dyes which is commonly used is fluorescein, another dye is rose bengal, and another dye is lissamine green. But the most commonly used dye is fluorescein. The most commonly used dye is fluorescein. They'll ask you a question, what fluorescein you'll use, whether freshly prepared fluorescein you'll use or fluorescein. The answer is you will only use freshly prepared fluorescein, because fluorescein, when it is stored, can be colonized by Pseudomonas. So then that becomes infected. So if you apply it to a patient's cornea, the infection can be transmitted to the patient's cornea. So you should not use stored fluorescein. Always it's good to use fresh fluorescein, and that fresh fluorescein is usually a violet colored solution, a thick violet colored solution, colored solution, And this solution, when it is applied to the eye, it is better to see it through a cobalt blue filter. This is a cobalt blue filter. The slit lamp has a special filter called a cobalt blue filter. So it allows only blue light. Can you see the blue light? Blue light. And the blue light will show the dark pink color of fluorescein as a green fluorescence. You can see the green fluorescence. That green fluorescence is from the stained fluorescein. You can see it nicely here. So if you see a fluorescein staining, then it means there is some pathology in the corneal layers. Similarly, you can use rose bengal. If you use rose bengal, it will stain more the dry areas of the eye. So in a dry eye, in the xerophthalmia, if you use rose bengal, you will stain better. And it will also stain the dead and debris of the eye can be also stained by rose bengal. Next is lissamine green. It's very rarely used dye. So here I want you to remember mainly fluorescein and the cobalt blue filter, and the ability to stain the eye is a very important technique of examination of the eye. Thanks. So with this, we'll go on to cornea 3 and try to build up on whatever basics we have learned in these two portions and try to understand corneal disease.